So good afternoon. I'm Dr. Sirak Mbaruke. I am a pediatrician, nephrologist. I'm in charge of pediatric special unit, pediatric critical care, and the pediatric renal unit. So today we are going to see one of the case, which was this thing induced acute kidney injuries, and they just see small pathophysiology and management of acute kidney injury associated with this thing. So welcome for this presentation. It will be short. I think you will enjoy. So the case is a 7 years old GN. He was a male. It was a date of admission of 7 February 2019. The presenting complaint was eye swelling for 60 days, generalized body swelling for 5 days, and inability to pass urine for 3 days. This at the time of admission at the International Hospital. The history of presenting illness, accidentally the child was stung by some of the bees 6 days prior admissions, was immediately developed facial swelling and the lip swelling, and they found unconsciousness by the neighbors. The child was taken to local hospital where was given injectable steroid and the piriton. So then regained the consciousness levels. Gaining the conscious levels, and was discharged at home for the first days. So the next 2 days, the child has facial and the lip swelling was worsened and had persistent generalized body swelling and body pain, and was now went today in other facilities. This is now the time now the child consulted the Nakuru level 5 hospital. The child was admitted in a critical care unit, was given anaphylactic, the diagnosis of the anaphylactic reactions, and was given IV hydrocortisone, start dose, started on ceftriaxone and oral antihistamine, and in progressions, the child had an anuria and the CNS deteriorations, and then it was referred to the International Hospital on day 3 of the incident. So the blood sample done at the Nakuru Provincial Hospital, there was a leukocytosis of 25, there was a neutrophilia of 82%, hemoglobin was 11, and the platelet was 152. The UEC sodium was slightly low at 130, normal potassium 4.8, urea was elevated at 32, creatinine 535, and the liver function test was reported normal. The finding at the International Hospital, general examinations, the child was sick looking, was generalized body swelling, noted to have a numerous sting lesions around the entire face, the neck, upper chest, and the entire back and the upper limbs. So the vitals at admission in pediatric emergency unit, the temperature was normal, 36.6, has a tachycardia of 140 per minute, and the increased respiratory rate of 36 per breath per minute, and has normal SpO2, 98% in normal air. On central nervous system examination, so the diagnosis made by the doctors who saw the child at the pediatric emergency unit was acute kidney injury due to multiple bee stings. So the plan was to admit the child to the ward, to do the blood work, full hemograms, see the protein, urea, and electrolyte, and the repeat liver function test. He did the blood gas analysis. He was catheterized, monitor input the output, and to have maintenance of fluid, and to call now renal team review as soon as possible. When now the child was reviewed by the renal team, the child was having severe facial edema with swelling of the lip and the tongues, was agitated and in severe pains. The vitals, respiratory rate was increasing now at 46 breaths per minute. Blood pressure was 110/50 millimeter of mercury. The heart rate was 138 beats per minute. The temperature was 37.2. And the LIFO criteria, when you consider now the creatinine of 432, the GFR was 9 mils per minute, because now the creatinine found that the second day was 529. On CNS examination, there was a retarded mental status. The glaucoma was improved slightly from 11 to 12/15. The child was still irritable and hallucinating. So he had normal tone, muscle bulk, and all the limbs were normal, but has restricted the neck movement because of the pain, the swelling. So the skin, there was a multiple sting lesions on the upper body, and there was scoriation marks of the stings. So the plan made immediately was scheduled for peritoneal dialysis and the high dose of metaprednisolone, antihistamine, monitor input output, and lab work, including creatinine kinase. So here are some work done at lab work done at Kenyatta. A white blood cells was elevated as of hemoglobin 20. 07 was leukocytosis, where predominance of neutrophilia, absolute neutrophil 16. Hemoglobin was now coming down at 9.7, now has anemia, and also the platelet to reduce at 150. So the kidney function test, now the child had hyponatremia due to delusional hyponatremia. Potassium was elevated at 6, urea was now increasing at 69, and the creatinine 529. So it's now showing the feature of the acute kidney injuries. For the liver function test, most of them were reading normal, and the coagulation profile INR was 1.1. Blood gas analysis was essentially metabolic acidosis with pH 7.2, PCO2 2.9, and the bicarbonate 13.5. So in a deep stick, they was able to concentrate the urine, and there was proteinuria of 2, there's no blood. How now the progress on the pediatric renal unit? After now the feed catheter insertion plus the day 2, the child was admitted immediately in the pediatric renal unit. So for day 2, there was still arterial limitations, reduced urine output, but at least we have now 0.3 ml per kilo per day from anuria. So, and that time we give ranitidine, and there was still indication it's not nowadays where the ranitidine, the cimetidine are out of now the market that are contraindicated. So, and we give metaprednisolone. So at day 3, there was slightly clinical improvement. The child was now able to sit and feed orally. The urine output improved from 0.3, 1.1 mils per kilo per hour. The facial swelling was reduced. There's no change in the management plan, remain the same management. So day 4, there is reduced now the body swelling generally, urine output increasing around 1.7 mils per kilo per day, and the old examination were normal. And now we stopped now metaprednisolone, and we start prednisolone 2 milligrams per kilo per day. So between day 5 and day 7, the child has a good urine output, normal renal functions. The peritoneal dialysis stopped, and the steroid was tapered off. So this is now the picture where you can observe a multiple correlation of the bee stings from the face, from the mouth, from the ears, and from the trunk. So, and here, this is admission. That's where we put in our peritoneal dialysis catheter. That's determining the child was just monitored in pediatric unit. So this is the graph where we check according to the renal function test. So this one we are just how was the trend. You can see now the trend from day 1, so to day 7. So the urine output initially you have 0 mils per kilo per hour. So we have progressions for the one who know nephrology. We found how for the children or adult to have acute tubular necrosis or acute nephritis. So we have the oliguric phase, then you have a polyuric phase, then you have stabilization. So initial 3 days you have been improving with the fluid, then you have a polyuric phase from day 4 to day 5, then normalizing in the year 69.1, these are two graphs. So at day 2, there are 3 reduced of the creatinine at 512 and the 54 until day 6 now, where we have now the creatinine of 106 and the urea of 17. And that's determined now we stop with the peritoneal dialysis. We continue to monitor the child until discharge, where now the creatinine was coming at 64 and urea 4.6. So at day 10, the child was discharged from pediatric epidemiology to the ward, and they stopped now the steroid. So we tapered down amoxicillin at the lower dose. We discharged from now the ward at day 15, and the no discharge medication. We are already off on steroid. We are off other medications. At week 2 after discharge, the child came back in our renal clinic. So we found the child was getting the normal functions of the kidney function and discharged from the renal clinic to stay with the parent. So now let's look about now the beasting. So beasting is a public health problems, and especially in intertropical regions. So greater the number of beasting, the worse prognosis. And the different clinical manifestations are common. Most common are local inflammation, severe allergic reactions, anaphylactic shock, and death. And the most common manifestations of these things are intravenous hemolysis, rhabdomyolysis, thrombocytopenia, acute kidney injury, acute hepatitis, and myocardial infarction. And our discussion today will be focused on acute kidney injury. We are not discussing for other complications. So for epidemiology, in 2011, so it was reported in 9,447 cases of this thing were registered in Brazil with incidence of 4.9 over 100,000 populations, and that one account 26 deaths. In the general population, 85% have a normal reaction to this thing, 10% would have now the large local reaction, and 4% have mild, which are cutaneous systemic reaction, and 1% has severe anaphylaxis. This is some from the Brazil. The systemic beasting reaction will be presented in 50%, and the large local reaction may be spotted in 37% for the beekeepers. So now that's when you consider the special in that professions. In a study of 43 cases where the caused by Africanized bees, 86% of the patient required the dialysis. So what is the pharmacology of bee venoms? So there are different types of the bees, and most of them are toxic, but the Apis mellifera circulata, which is Africanized bee, is the most killer than other types. So it's usually located in East Africa, Italy, and Brazil. So it is sensitive to slight disturbance of their colony, and frequently the attackers the massive, and the venom freely filtrated by the glomeruli is absorbed mainly by the proximal tubules. So the pharmacology of distinct venoms, it has different types of the complex, and it has major the protein and peptide. So the protein, you have phospholipase A2, we have ironidase, and the peptide, you have methyl, dopamine, histamine, dopamine, and norepinephrine. So mainly the methyl, the phospholipase A2, they has to lactic acid that act on the phospholipid membrane of blood cells, and the vascular endothelium are the potential cause of the hemolysis in terms of these things associated with acute kidney injuries. So Here we can have, for example, now the summaries, and those summary how the percentage of each toxins for these things. You found the milking has 50% the concentrations, and the action can be cause hemolysis, cause the vasoactive. It causes now the contraction of the blood vessels, which causes rhabdomyolysis, and the cell antimembrane properties this. So phospholipase A2 has 12% of all the toxin, and usually the main action for the is just to cause the cell membrane lysis. And the epamine, it has now the 2%, but it's now mainly just the neurotoxins. And usually how it works, it causes now the peripheral nerve dysfunctions, and it causes neurotoxin by blocking potassium channels. And that one will cause systemic vasodilations and progenitor shock. So we can have also mastolytic peptide, which are 2%, which causes cytolysis and histamine release. And histamine release will cause now the edema and the pains. Ironidase 2, ironidase, I'm sorry, has 1, 2, 3% of the venoms, and cause cell membrane lysis, which causes usually rhabdomyolysis. Histamine is 0.1 to 3%, and increasing vascular permeabilities, which will cause now edema and the swelling. It causes also the pains, and it can reduce also the vascular, it causes vascular permeability, and cause now the edema to be generated, especially in the lungs. Also, it can cause a lower blood pressure if the venom is massive. Dopamine is less than 1%. So dopamine has a fighting hemodynamic effect, which will cause now especially the tachycardia. So when reduce now the cardiac output, and now that one will trigger the lower blood pressure. So minimine is less 1%. So it's similar to phospholipase A2. And phospholipase B less than 1% because cell membrane lysis. So which causes now rhabdomyolysis, and you have now the myoglobin capillary of the kidneys, which now block the permeability of blood vessels. So there's reductions of the blood supply. That one causes anoxia, and because now acute tubular necrosis. So in the other informations, the maintaining promoted use of catecholamine, it increases the capillary blood flow and the cell permeabilities, enhances the speed of the venom within other cells, and the maintaining cause cardiovascular collapse and the death in massive envenomation. The phospholipase A2 produces rhabdomyolysis in skeletal and the cardiac muscles, hepatocellular lesions, and the formation of the pro-inflammatory substances like bradykinin and the serotonin. So epamine, as I say, is also caused a neurotoxin by blocking potassium channels, is responsible for peripheral nerve dysfunctions, and the other pharmacology is systemic vasodilation, severe hypertension, and the decreased renal blood flow, and predisposed to the acute kidney injury as now acute tubular necrosis. So while iron disease, it facilitates the distribution of other venomous component through tissue surrounding the distinct site. So now how the pathophysiology of the acute kidney injury in this thing. So usually it's synergic actions of those toxins, including iron disease, phospholipase A2, melting, epamine, to direct cytotoxic renal injury and the kidney hypoperfusions. So all those substances induce vasoactive mediators. So usually histamine, serotonin, norepinephrine, bradykinin, the prostaglandin. So those one the increase now vasoconstrictions and reduce now the kidney blood flow, which was acute tubular necrosis. So they increase also the afferent arterioles of the kidneys to increase the vasoconstrictions. So at that, so it also reduce the glomerular filtrations, and they reduce the peritubular blood flow, and now they cause renal ischemic and the ATN. So in both this thing, we have ischemic acute kidney injury in the acute tubular necrosis. So just for the remembering, maybe for the one who attended the letter, rhabdomyolysis promote renal vasoconstrictions, formation of the intratubular deposit for myoglobin, the cytotoxicity of myoglobin to renal tubules, said by production of free radicals, causing lipid oxidations and cell damage. And also, it can cause the IC, which is thromboplastin enhanced formation of microthrombin to the glomeruli. So in just summary, the pathophysiology of this thing, so you have now this thing, so it will be depend how massive of envenomations. So this thing is just this thing will deliver now the bivenomous toxin into the blood systems. So now it have 4 effects. So now one, it will be now effect on the skeletal muscles, which will cause rhabdomyolysis. And as you saw in up, rhabdomyolysis will cause now the myoglobins, which will block now the blood flow. So it will have now effect of the blood cells, which will cause now hemolysis. And once it causes now hemolysis, will cause now the IC and cause acute tubular necrosis. So also, the venom itself can cause nephrotoxic substances by diet and nephrotoxicities, and all those will cause acute tubular necrosis. So in the other side, so those substances which will include now vasodilation and increase tachycardia into the blood systems, so we reduce now the vascular permeabilities and increase the heart rate, and that one will reduce the renal perfusions, and that one will cause renal ischemia. So basically, in this thing, you have two main components of acute kidney injury. We have renal ischemia, and you have acute tubular necrosis. So in the outcome, it will be depends which part is more prominent than in other ones. So how the clinical manifestation? So the clinical manifestation are different from one person to another person. Also, how many stings, and also where now there was this thing. So you can see edema of the palms. You can see now this one is having now edema, and you have the cellulitis. You can have multiple skin scoriations. You can see this man how the mouth, the nose, and the eyes have been swollen, has anaphylaxis, and so you can see this red house. So there was periorbital swelling and facial swelling. So you can have a different manifestation from the mild local swelling to anaphylactic reaction and this. So when, for example, we can just maybe what we found when you have maybe a patient who had this thing, and what is supposed to tracked by our clinical examination. So by the skin, which is the grade 1, the patient will come just having the itching and the flashing, maybe sign of the urticaria in the angioedema, but in the other system, there is no other problems. So by stage 2, we have the itching, flashing, urticaria, and angioedema. In the abdomen, you have nausea and the cramps. And in the upper respiratory systems, we can have nausea and the hoarseness of the voice and the dyspnea. So this is the patient who has the issue of the laryngeal edema, and the one support to write very fast by intubations. So now in the cardiovascular systems, we have now tachycardia, where the heart rate will increase more than 20 per minute than the normal heart rate. We have hypertension, and you have the blood pressure, which will be drops. Once now we still have also the arrhythmia and the persistent tachycardia. So that's the patient. Once you receive the patient, we support to look about those symptoms and those signs when we do triage. So stage 3 is so for the anaphylactic reactions, we have vomiting and the defecations. So we have laryngeal edema, bronchospasm, and cyanosis of the extremities. And in cardiovascular, now the patient will have shock, anaphylactic shock. So stage 4, so this one remains the same. We have the vomiting, defecation. We can have a respiratory arrest, and you can have circulatory arrest. So basically, those grades help us to make the diagnosis, also to entertain how fast we support to intervene and how we call the help. So what is now the laboratory finding for the patient who had these things? So as you saw for our patient, on complete blood count, usually you have leukocytosis and you have eosinophilia. Usually you have lower hemoglobin because of hemolysis and the thrombocytopenias. So in urinalysis, you may have hematuria, secondary to myoglobinuria or hemolysis, proteinuria. You can have also hemoglobinuria, leukocyturia, and hemoglobin or myoglobin pigment cylinder in the urinalysis. So usually you can have increased fraction associated with the sodiums, especially when the patient is not taking the adequate fluid and when you have acute ischemic necrosis. So in terms of the kidney function test, you have elevated the urea, creatinine, and usually you have a hyperkalemia. The blood gas analysis, most of the patients, they show now the metabolic acidosis. And the liver function test, you can have a normal or the elevated transaminase, LDH will be increased because of the bleeding, and you have the lower albumin levels. Muscular enzyme, you may have elevated the serum creatinine phosphokinase, and in coagulation profile, usually most of the patients, they have elevated the iron. So the management. So usually management are supportive care, and it requires all the team to intervene very fast. So according to European Academy of Allergies and Clinical Immunology, recent guideline, you do assessing using ABCD approach should promptly applied to patients with anaphylaxis. And the cardiopulmonary resuscitation should be immediately instituted if cardiorespiratory arrest occurs. So the first, if you are on the spot, so you support to remove the previous created stings. That one should be carried out as soon as possible. And the type of removal is supposed to be either scraping or pinching without squeezing. Because the more you squeeze, the more you cause the pains, and the more you increase the toxin to move around. So this approach should not delay the medical treatment. So even if you found these things, just removing these things should not delay the medical management, especially you assess your airway, breathing, cardiovascular, and the exposures. So the epinephrine is a cornerstone of the management for these things, and it's the first line of intervention before other approaches. So by airway, you always support the airway and the monitor oxygen saturations. And in the breathing, so it's better to have tracheal intubation if presence of the stridor and sign of the respiratory failure, especially if you have laryngeal edema and pulmonary edema. So usually you recommend to lower limb elevation, at least to increase nowadays venous return, to increase the blood pressure, that is C. And also IV steroid, you support to give it the bolus in the maintenance of fluid according to the response. So also you are recommended for antihistamine if there is sign of the angioedema and if there is sign of the urticarias. So the corticosteroid in conjunction with the histamine should be maintained at least for 5 days, at least for 5 days. So you remember for now for the exposure, support to have urinary catheter, support to monitor daily blood pressure, support to be in normal range, and try to keep it in normal range either by give antihypertensive drugs or either by initiative the dialysis. So you support now to correct electrolyte abnormality and acid-base disorder. So by binding hyperkalemia and treating the metabolic acidosis by sodium bicarbonate. And if not there, so if you are unable to correct by metabolic acidosis by sodium bicarbonate, you support to do the urgency dialysis. So if you have now what is now indication for dialysis, we support to be now uremic encephalopathy, fluid overload, refractory hyperkalemia, refractory metabolic acidosis, anuria or oliguria, and the multiple organ dysfunctions. So other study shows now plasmapheresis have been used in conjunction with hemodialysis in some situations as an important means for removing venoms. However, the plasmapheresis is a good procedure, but it's expensive. So it can cost almost more than 100,000. So not everyone can afford. So what is now our take-home message? So this thing is a medical emergency, and usually the procedure of the triage management is just always to follow up with the airway. Just check the airway, monitor oxygen saturations. If now you are intending the laryngeal edema, you secure now by endotracheal intubations for breathing. So cardiovascular support to monitor blood pressure, have the catheter, have the food runnings, and you don't forget to give the adrenaline as long as you get your IV. And for D, you support to monitor now urine output, to monitor Glasgow coma score, to monitor your fluid, to monitor your electrolyte, and other investigations. So anaphylaxis should always be suspected and treated after these things. And the management for acute kidney injury can be a combination of monitoring input in the output, monitor blood pressure, and the seriophysical and the laboratory monitoring. So of course, by supported by the dialysis. So in all the recommendation, if you have a AKI associated by this thing, earlier dialysis is life-saving. Don't delay. Just if people stay far, refer earlier, you may save most for the patient. So the mortality of these things, it can be estimated between 15 to 25. It depends how now the inoculation of this thing. Those are my references. And thank you so much. This is the time now for questions and suggestions. I can answer some questions. So the first question, what was now ranitidine on the profile? So you remember the ranitidine, the cimetidine, and antihistamines, and at that time was still used in the market. So the indication one was the antihistamine treatment. The second indication was to treat now to treat and prevent the gastric ulcers. So it was removed on the market later on, but that time was on the market. So the second question is what happened to the liver function test that looked abnormal at admission. So the ALT was elevated, and that one was because of the toxin of the bee sting, but also it is another entity called the hepatorenal syndromes. So when you have the renal injuries, acute renal injury also can trigger acute liver injuries. And when you treat now the acute kidney injury, it was mostly the cause, also the liver function is normalized. So number 3, what is your dosage for adrenaline or epinephrine when dealing with the anaphylactic reaction of this thing? It is the normal dose we are using for other patients, but you support to repeat every 6 hours according to the response, and you give now at 0.001 per kilos unit. So now what is the, thank you for your detailed information that. So now there's another question, says, will the bee sting reduce the white blood cells? So maybe for there is another cause, but usually bee sting is increasing the white blood cells, not just increasing, but when the technician will do complete blood count, because there is increasing hemolysis, they found now immature white blood cells. That's what we found now in cytosis. So, what is another question? So another one questioning, could you slide be shared, please? Yeah, that one I can share. Just send me your email. So another question will says, hi doc, how come some people do not relate to bee sting, even multiple sting as witness bee handler while harvesting honeys? So you remember our genetic and our response to everything are different. Some people are having higher allergies, depending on also the level of immunoglobulin E we have in our blood. So that's why some people are not responding, other one are not. Some people are not reacting, other one are reacting. That usually it depends how the genetic materials everyone see. That one is the genetic materials, and also the percentage of IV immunoglobulin we have in our bodies. So, is it the role of hydrocortisone? Yes, there is a role of hydrocortisone, and that one has been used even at the Nakuru Provincial Hospital, where the child was coming from. And when the child came, because we found now there's proteinuria and there was a elevation of the kidney function test and worsen with the conditions, we jump up on methylprednisolone at 10 milligram per kilo per dose. I think other are just people who are just requesting to share with the presentations. That one I consider, and I will share with the presentations. So another question, how do you manage edema caused by these things? So edema usually is managed by giving the antihistamine. So you can give chlorpheniramines, you can give cetirizines, and if edema is not reducing, we will give now the steroid. So the steroid has a lot to reduce the general inflammation. So there is one who is asking what is the prognosis. So the prognosis for these things in the acute kidney injury usually is not a good. So the mortality is very high. So because when you have usually this thing associated acute kidney injury, also most of the patients they have the multiple organ dysfunction, including now thrombocytopenia, anemia, a liver abnormal liver function it is. So usually the mortality can be high, as I said, between 15 to 25. Also other factors increasing in mortality, it depends on the age of the patient and how the person is sensitive to this thing. So there is one who is asking, in the case of anaphylactic shock, how does one detect? So anaphylactic shock is detected by combination of the clinical examination, where we check the patient. Usually there is a score you can use for the one who work in ICU, they know. But usually the simple things you check the sign of the airway airway and the breathing, especially the patient was mouth swelling, eye swelling, and the sign of the angioedema. Amsonolaryngral edema, the patient has no stridor. So that's for the airway. For the breathing, the patient may have the saturations and have feature of the primary edema. And the on cardiovascular, initial presentation for the anaphylactic reaction, the patient will have now tachycardia and the lower blood pressure or medium normal blood pressure. And if now there is a delay for the corrections, the patient will have bradycardia and severe profuse hypertension. So in the gas in the CNS, the patient will have elevated level of the consciousness. So now to make the diagnosis support combine all those clinical scenario to make a diagnosis of the anaphylactic reaction.
Thank you, Dr. Syriac, for that presentation. I don't know, are you able to see any questions? I can't see any questions on my end.
I saw all of them and they answered. I think I answered all of them, yeah.
You've answered most of them, huh?
Yeah, I answered all of them, yes.
Okay, okay. All right, then thank you so much for accepting to give us this very interesting presentation on acute kidney injury as a result of a beasting and all the other notes that we've gotten from this topic. Thank you very much. I don't know if there are any other questions. There's one who Asila was asking, does the venom produced cross to the CNS system?
So no, there's a word called the mericin. Mericin is the one of the toxin which will cause now the CNS. And we said, can you just go for the slide? And we say now for the mericins and the apamine, usually they cause now the nerve dysfunctions and they block out the potassium channels. So that's why they work. But mainly just they block the potassium channels and they cause now the reduction of the impulse because there's no impulse when you do the stimulation of the nerves. So that's how they work. Also, they are not other one effect with the CNS. It's because of now the degradation of the blood pressure. You have lower blood pressure. The brain is not well perfused. So you have accumulation of the lactic acidosis. And those one also include a lot of inflammatory mediators, and also those one cause now feature of the CNS. So there is a combination of the effect of the toxin immediately with cytotoxic effect, and also by the lower blood pressure and the lower perfusion of the brain.
Thank you for that. I can't see any other question. The rest are just asking for the slides. This can be found. They'll be posted together with the recording at the website. Yeah. Thank you again, Dr. Syriac, for that very interesting presentation and very informative presentation. I think if there are no further questions, then maybe Syriac, if you'd like to give a closing remark.
Okay, thank you so much for giving me these opportunities. We have been just assisting some children. I think some of you guys, you remember the history of this thing at Kabete. I think it was 2020, where I found so many children. But the one who came was were 3, were very sick, and they were dialyzed, and we give them medication according to those protocols, and all of them they recovered and they got away. So Just to remembering our group discussions with our partner doctors, nurses, clinical officer working in other facilities. So we still have opportunity to serve so many patients as long as you send them earlier. So we are ready to receive and help for those patients. Just call us and send the patient area, and you are most welcome. Thank you for these opportunities. It is just learning sessions. Let's work together and improve in our healthcare.
Thank you, Dr. Syriac. I think I'll close the meeting. Yeah, thank you again.
Thank you, Dr.